Let me introduce Rafa Fernandez and Umberto Lucangelo. Did I pronounce it right?
Yes, correct.
I can't believe it. Rafa is from Barcelona area, and Umberto is from Trieste. Both of them have experience in the topic they're going to make reference to. Rafa has been studying HAV for a while, and Umberto uses neurally adjusted ventilatory assist on a regular basis. So they're going to give us some ideas about what they do, what the problems, what the issues are, etc. Umberto?
Thanks.
Do we have the wireless one so that it's easy to...
No, well, no,
press.
Okay. Well, thank you very much, Bob. It's a big pleasure for me to be here, and I was trying to thank Bob for his warm hospitality. So, what I'm going to speak with you today is about Nava. And Nava is a device that adopts a diaphragm activity instead of pneumatic signal that currently drive and control the ventilator. So I will start with just a brief introduction about Nava, and then I tell you something about some technical problems, and at the end I would like to show you some clinical aspect with the Nava application. Actually, we detect the flow and pressure volume at the airway. Nava technology detects the diaphragm excitation by use a nasogastric catheter. And in this case, we know what happened when the cerebral activation by the phrenic nerve active the diaphragm, and the tidal volume is guaranteed. During illness, this activation increases, and it's important to know that the diaphragm becomes weak if the load, respiratory load, change, and that the diaphragm try to guarantee tidal volume, increasing the electrical activity of own cells. Well, the inventor, 20 years to have this device, and briefly, just to show you the electrical behavior that is made by 8 channels placed in the nasogastrical tubes, and the signal is collected in instead of time domain in frequency domain. It is allowed to have a signal like this, and the shape of this signal represents the LTI signal that could be pilot the ventilator. Briefly, we have to inside in the esophagus the catheter. The catheter is provided by 8 channels that detect the electrical activity inside the diaphragm. One of the most important things is to be sure that we are in the right place, and the procedure use the electrical activity of ECG, as you can see here, and when the catheter is correctly placed, the green trace appear in the middle of the 4 trace of ECG. If we are too far, the trace come up in the ECG, or on the contrary, come down. Well, in this case, we can use ADI as a monitoring. We have pressure, flow, and volume curve, and at the end, the electrical activity of the patient. This is very important because Nava allows us to make a pressure support for the patient that has the same shape of the electrical activity. But to be sure to not make damage of the patient, we have to prepare the patient in terms of Nava preview. That means that on this curve we have to make a gain that should be almost equal to the level of the previous pressure applied to the patient. The gain is, in this case, 2 times, and this curve is multiplied for 2 times, it is double, and we arrive until this value of pressure. The gain can change from 0.5 to 10, and also trigger is a big topic in Nava modality, and the trigger, as every device that should be sensitive to a signal, is around 0.5 microvolt. The ADI is defined in microvolt, and there is a lot of intervariability between patients, so there is not a standard measurement because every patient has his own electrical activity. And now we run with Nava mode, and as you can see, this is the ADI curve, and the correspective pressure applied to the patient has the same shape of the ADI. Well, just briefly to tell you that if the ADI signal is loose, there are a safety changes in pressure support or in backup. Okay, why we can lose ADI signal? For instance, because the catheter is disconnected. But, and now I want to start with the clinical part. Sometimes happen that the patient is sedate, has nerve disorder, or of course muscle relaxant. But one of the most important points that I want to show you is that the patient should be hyperventilated, so over-treated. In this case, this patient, flow curve, pressure curve is pressure supported ventilated, and the trace seem very well, seem very normal. But if we go to see the electrical activity of this patient, we saw this, flat.
It's a paralyzed patient. Neuromuscular patient.
It's not paralyzed.
I mean, oh, okay.
It's not paralyzed. It's not paralyzed. This happened because this patient is over-treated, it's over-ventilated, the PCO2 is low, and this is the patient that everybody wants to have. Because when the patient is connected to the ventilator, okay,
There's no problem.
No problem, no alarm rings, okay, the physician is happy, the nurse is happy, everybody is happy, but the patient is not happy.
Right.
Because his electrical activity is completely flat. And just to be sure that we produce a damage when the electric activity is flat, everybody knows this study, and we know that the muscle fiber of the diaphragm became atrophic in 18 to 16 hours. Okay? Became atrophic. If we don't use the diaphragm in this small range of time, we have a diaphragmatic injury. So this is the reason, because sometimes the patient is not so easy to win, or the patient is not so able to interact properly with the ventilator. So our big problem is patient-machine ventilator, patient-machine, interaction. And Nava also can help us in this contest. And Nava is an important tool when we speak about patient ventilator asynchrony. Easy report, the most important point that can produce asynchrony. One of these are the trigger system that produces important delay. Everybody knows the difference between pressure and flow trigger?
Don't believe that.
No? Yeah.
Oh,
Oh, please. And when we play with the narrow trigger, the delay that in this airway pressure occur disappear with the other system. But just to go a little further, basically we can define two different kind of patient ventilator asynchrony: timing asynchrony and flow assist asynchrony. Can Nava help us to define this phenomenon? Yes, in this study we can see here in this slide trace of pressure, flow, volume, and ADI, and these values are also reported on the pressure curve. The horizontal arrow defines the time delay, so a time asynchrony. We have an ineffective effort. In this case, the electrical activity is adequate for the patient, but in this other case, the electrical activity is very high. So this is introduced the other possibility to have the asynchrony that is the flow asynchrony that happens when we have a discrepancy between the amplitude of the narrow respiratory output and the level of the respiratory assist provided by the ventilator. In this case, this is our curve. ADI, green, red, pressure and flow, no patient effort, and you can see how the patient have a big electrical activity inside the respiratory time and produce the particular different shape and different slope in the flow curve, and just a little bit shape in the pressure curve. We are in pressure control in this case. Similar results can be seen in volume control, and look at in this part during the post-inspiratory pause as the patient requires more flow and has a lot of electrical activity because his brain, his central output requires more flow, and the machine, the ventilator, do not allow. Other curve, in this case, you can see, because you work with the patient, that there are just a little difference during this expiratory phase, a little shape change here, and if we go to see the electrical activity, we can realize that these are properly triggered, but the other one, they are ineffective effort. That I don't know if without the electrical activity, who is able to identify this just to see the ventilator. Another one that is more secret patient, and we have a lot of electrical activity that is completely out of phase of the ventilator activity. Well, Nava is also could be also used in intubated patient and in patient with non-invasive ventilation. In this study, we can see how changing by pressure support in intubated patient, we have flow curve, then the volume curve is the the other one gray, and here we have pressure and ADI. When we switch from pressure support to Nava ventilation, we can realize how all the asynchrony disappeared and how the patient is correctly ventilated. The same happened during non-invasive ventilation. This is helmet ventilation, pressure support, and Nava ventilation in the same patient after the switch. So the message is Nava is not only a monitor to see what's happened in the diaphragm, but it's also a modality to try to decrease asynchrony and to try to follow the patient more properly. Another important issue is how have we to treat the patient. This means sometimes the Nava level is not correctly selected. So in this study, show us how to make a correct treatment of the patient by increasing step by step the Nava gain. It means that at the beginning the Nava is increased and the ADTI tend to decrease. We can see that the pressure increase, but when the support is enough for the patient, we have a decrease in the ADI and stabilization of the peak pressure and of the tidal volume. If we go further, if we increase more the Nava level, obviously we have an increase in peak pressure, an increase in volume, and in the decrease in electrical diaphragmatic activity. And this is very easy to do by the ventilator, because the ventilator, the servo eye, allow us to have the trend and to make a titillation of these parameters. So Brander said that systematically increase the Nava level, reduce respiratory drive, unload respiratory muscle, and offer some advantages. And what about cardiopulmonary function? Because we are people, we are lung people, but we have not to forget that the patient between the lung has a heart. So this is a recent study who consider the effect of Nava with the same titration that I showed you before when we switch cardiac patient, intubated cardiac patient from pressure support to Nava. And what happened? Happened that during pressure support, we can note that the esophageal pressure has a negative phase that disappears with the highest level of pressure support, but this negative phase is still maintained during all Nava trial. This means that the Nava trial is more physiologic, is more associated with the physiological behavior of the lung and the heart interaction than the pressure support. And also the variation in central venous pressure and in the pulmonary pressure is less. So the author conclude that Nava is a ventilation that is similar to spontaneous breathing, regardless of the Nava level, and decrease the impedance and the venous return to during the lung inflation produce a better cardiac output. Okay, thus, Nava not only prevents lung overdistension and potentially diaphragm disease, but also the characteristic side effects of positive pressure ventilation or right ventricular function. This is my last slide because I want to stress this concept. Nava is a new tool, quite a lot of new tool. It's not the magic ball because it's not the tool that can produce the miracle, but it's windows that allow us to see what's happened during mechanical ventilation, during non-invasive ventilation. But the first aim that we have to remember is that we have to adapt the ventilator, not to adapt the patient to the ventilator. And probably Nava allows us to think about it, just to have this better picture between the two men instead that machine and the man that I previously showed. Thanks.
Do we want to let Rafa do his presentation and then we can talk in general about the two and contrast them?
Okay.
Okay.
You can use the new keyboard if you want to.
The bold one.
This one.
Better, yeah. But if not, I have to hold back. Okay.
You can use that.
Thank you very much. I want also to thank Bob for his kind invitation to share with you some of our experiences along this year. And I have also to explain that for us coming for this little town outside Spain to go here, that reminds me of my first times in the medical school, when we start to learn that there is some place like that that appears in the most famous journal of medicine around the world. They say these guys are very smart, so they excuse patients in the pages of the journal very cleverly. So say, no, you have to go there and try to explain them something new for them. So to start with that and to know a little bit more my audience, one of you are treating day by day patients under mechanical ventilation. Can you raise your hand? Okay. For having a better picture on that, how many of you are using commonly Nava? No one. How many of you are using commonly PAD? PAD? One. So we are almost in a equilibrium position from the start. No? So.
That's why I asked you to do this.
Yeah. So now my point is more from a clinical point of view. I discussed with Bob what can be the best approach for that. If make a big review about the fundamentals of proportional assist ventilation, or what is our last sensations about years and years of using this modality. So let me take a little explanation about my presentation. I focus my presentation in the most strong way of showing clinical research, that this is a randomized control trial. Doesn't it? Okay, so we made a randomized control trial on proportional assist ventilation compared with ordinary assist control ventilation. So, and our point was to start not as the majority of papers that you can read that are focused on weaning patients, because it's a supposed partial support ventilation method. People has selected this method only for patients that are trying to go out of ventilation. So most of the papers that you can reach are focused on weaning patients. But we say that maybe a very interesting point can be to start from the very beginning with a method that allows the patients to breathe spontaneously, if there is any reason for doing that. as you are fully aware, control modes are the routine method used in the acute phase of respiratory failure. Patients, because at that time, our objectives are to ensure the adequate gas exchange for those sick, very sick patients. And we also want to replace the muscular effort that are exhausting against deteriorated respiratory mechanics, and it clearly is a good point for that. And also, in the last year, we want also to avoid ventilator-induced lung injury that can be produced when the patient wants to take more air, so they are taking big tidal volumes that at the long term can damage their lungs. But you also know that this is something side effects on that, because for that there is a suboptimal patient-ventilator interaction. You have to be a very expert in mechanical ventilation to set the machine in assist control mode to clearly match the ventilatory needs of the patient. And also, when nothing works properly, we need to increase sedation or even relaxation. So, and just Humberto has just reviewed for you that those periods of absolute lack of activity of the diaphragm can have long-term deleterious effects in terms of atrophy. So maybe this is a good part, but we have to balance the side effects of the other one. So this was the reason why we think what can be the role of proportional assist ventilation to try to fight all these difficult points. Proportional assist ventilation, I want to remind you that delivers assistance in proportion of the instantaneous flow and volume that already generates the patient. So the machine waits until the point that the patient makes any effort. This effort produces some flow and volume. So the machine multiplies this by a number that we can set. We set that by setting the gain, that is the percentage of the total pressure calculated that needs to be done to introduce the air into the lungs. So if the patient makes a kind of effort, we can produce that the machine makes twice that effort, or 3 times or 4 times the effort that has actually produced in the patient. For that, he needs a semi-continuous monitoring of respiratory mechanics, because the way of calculating how much work must do the machine is because he knows the mechanics of the lungs. So it says if the patient gets this air against this bad mechanics, he needs an exact amount of pressure. So we want to multiply this pressure. And this is clearly clinician operated. So the clinician has to decide how much help he wants to support the patient. 20%, 80% is in your hands. The supposed advantages are that the patient can maintain his own respiratory breathing pattern, because we only support his respiratory muscles by adding pressure in each breath, but the patient is able to decide the rate that he wants, the tidal volume that he wants. And it's clear that that improves synchrony and reduces sedation requirement, because the patient is more comfortable. And this is a regular thing observed in any study. As a small review of how works proportional assist ventilation, I want to go to a little bit basics about that. This is the most simple way that I can offer to you, showing what is the ventilatory coupling. In normal people, if you plot the inspiratory effort developed by the patient, as much as the inspiratory effort goes up, the tidal volume goes up too, in a linear fashion. That is the mechanics of the lung. This is actually our rate, our pattern of breathing here. For some more active, for some more relaxed, is this kind of way. Okay, but what happens with disease? With disease, the disturbance in mechanics makes that for the same effort that before you get this tidal volume, when you become ill, for the same effort you get less and less volume. So then you need to go making more and more effort to try to find the same tidal volume. And what is our behavior with patients? They become dyspneic and even tachypneic to try to find the volume that they want. So they need more effort to get the volume. And this is the reason why they finally fail and need to be intubated, because they become exhausted because the high respiratory count. So the nice thing of proportional assist ventilation is to try to go there by making this extra effort that the patient needs. Proportional assist ventilation doesn't improve mechanics, but only reduce the inspiratory effort by the patient, because they make the rest of the effort. And we can decide, depending on the severity of the illness, how much help the patients need. So this is our theoretical approach of how can work proportional assist ventilation. The differential point that starts on the clinical use of proportional assist ventilation is the ability of machines to continuously monitoring mechanics on the patient that the inventor of proportional assist ventilation explained years ago, that after one supported breath, you see that pressure, this patient triggers the machine, the pressure goes up, multiplying the volume and flow observed, and after that, it puts randomly an inspiratory pause in which the flow is stopped, and you can see that the pressure goes a little bit up. When the respiratory muscles relax, you have only the passive pressure inside the lungs. So with this pressure and this volume, you can calculate compliance, and because of the previous flow, you can calculate resistance. So the machine goes thus in a randomly way every 3, 6, 7 breaths. He introduces this interruption to continuously calculate mechanics. And then you can say only, I want to multiply this by a certain amount of percentage. A very important thing if you want to use proportional assist ventilation is that everything happens after the patient starts inspiration. So anyone that happens before starting inspiration is blind for the machine. And one of the important things in your patients is autopsy. If your patient has autopsy, they must make an effort to compensate for this pressure before starting any flow. So all this effort will be blind for the machine of proportional assist ventilation. And I can show you here that no matter what is the indicator that you use, PO1, pressure time product, for patients in spontaneous ventilation, if you with COPD and autopsy, you can compensate part of the extra work by CPAP, compensing autopsy. You can also reduce the effort by using PAP, but the good thing is to compensate for both things. CPAP will compensate for autopsy, and after inspiration starts, PAP will compensate for extra work during inspiration. So take always in your head that autopsy is outside the abilities of proportional assist ventilation for working on that. And the other one is, how can you decide the amount of help that the patient needs? Do you have any bias about that? Always some time of help? Always 100% of help?
No, usually between 50 and 70% we start.
Between 50 and 70 will be your start, but based on any approach, that you mean that maybe 50% is enough for the spontaneous patient to sustain in the long term?
We're trying for a work of breathing above 0.5 joules, so
because the machine also offers some kind of work of breathing.
Yeah. So whatever support we need for that.
This is a good point from the clinician. From the clinical point of view, you can select the calculation of the machine that says, if I support as much as pressure, I can understand that the rest of the effort done by the patient represents a certain amount of work of breathing. But you also have to take into consideration that that can be a normal work of breathing, can be very exhausting for a very weak patient. So sometimes these kind of approaches are good for fit patients, but can be a wrong decision in very, very sick patients. Because even to try to sustain normal work of breathing for a very weak patient can be very exhausting. So you have to think about what is the amount And you also can go to the other part to say, ask to the patient, are you comfortable enough or not? So this is another approach that the people working in France decide that we don't rely on the sophisticated calculation of the machine, but you can go backwards to calculate what is the pressure that the patient develops in every breath. So they construct this kind of table in which if you use the change in pressure from end expiratory pressure to PEEP developed by the machine, you can anticipate what is the mirror effort done by the patient, depending on the percentage of assistance that you use. So they construct this kind of table in which also, again, they make these black lines are the ones that make pressure by the patient that commonly are accepted as normal. So we can go, we have to decide what percentage of help you want to use, depending on the mechanics, what can be the pressure developed to the patient to avoid also atrophy. If we use 100% of help, they will be atrophic. So we have to move between atrophy and exhaustion. So they say it this way, but again, it doesn't compensate for the thing that 10 centimeters of water can be sustainable for you and me, but maybe it's too exhausting for a very weak patient. So always you need to put clinical sense in all of that. So with this approach, the authors suggest this kind of algorithm to adjust again. They say you have to start here with a 50% as you currently state, and you can put your alarms to avoid high pressure, high rate, high tidal volume, very low tidal volume, so on, and you can start. So you can find if the calculated in that table of the muscular pressure is very low, and you don't want that because the patient will be atrophic in the long term, they suggest to decrease the gain and look at what happens. On the opposite way, if the calculated muscular pressure developed by the patient is too high and the patient will be exhausted, they suggest to increase the gain in 10% until you find the safety area. And what happens if you are in the middle, in the supposed target range? This is not enough. You have to be sure that you are getting this without too much trouble. So they say, what is the tidal volume that the patient is getting? This is higher than 10 milliliters per kilogram body weight. They suggest maybe this is not good for the patient, or this develops respiratory alkalosis. So it means that the respiratory center of the patient is not smart enough to clearly compensate for the minimum needs. So the patient, even with the help, gets high tidal volume and hyperventilates. Something happens in his brain that doesn't stop when there is enough. So they suggest to decrease the gain in steps of 10% and look what happens with this. In the opposite way, if the patient with this calculated pressure still develops signs of acute respiratory failure, the tidal volume is very, very low, or maintains respiratory acidosis, they suggest to increase the gain. So they say, why? If the pressure is okay, why the patient doesn't compensate, doesn't make bigger effort to get more air? Do you have any suspicion? Because maybe it's because it's so weak that it's unable to make more than these 5 centimeters of pressure. So as much as the machine helps for a 50%, the patient still remains stagnant and acidotic. So it's a suggestion that the pressure can be good, but the patient is unable to cope with that. So they suggest again to. So with all these basic things about proportional assist ventilation, we construct our trial in which our hypothesis of working was that high assist and proportional, I mean 80% gain always, should be almost comparable with assist-controlled ventilation. We know for sure that it's not 100% rest for the patient, but we suggest that 80% is almost comparable to unload the respiratory muscles and to start in the acute phase of critical patients. The projection was that there should be a better patient ventilator synchrony in patients with proportional than in patients with control, that then they will need lower sedation, and probably they will account for lower days in the ventilator. This is how it was our positive approach. Any bias about that? Do you think that can be reasonable? Yeah? So our objectives were to reduce the mechanical ventilation days in patients when you use PAP instead of controlled ventilation in acute phase, and also to look what happens with gas exchange, respiratory mechanics, length of stay in the ICU and hospital, and even, if it is possible, to show any improvement in survival. Okay? The study was done in 4 different centers in our region around Barcelona, and some of the important points to understand the difficulty to enrollment was that we used patients in the first 24 hours after the intubation, but for sure are not expected to be extubated the next day, because if not, there is no sense of that. We also want to escape to the very, very sick patients, the very difficult patients that no one is prepared to allow for spontaneous breathing. So we take patients with not very severe requirements of oxygenation or very high levels of PEEP. Also, we need for sure that they were not in deep sedation, because then they are unable to trigger the machine. And also because our previous studies, we select patients with compliance not terrible or not enormous resistant troubles, or that they don't develop this enormous amount of water breathing. So we try to in a pragmatic way of study, to try to avoid the most controversial patient, the more difficult one, that probably is very difficult for ordinary physicians to accept that we can play with them and try to make a trial with an spontaneous breathing in patients with ARDS or something. So the patients were randomized by a coordinating center, and we collect data daily with our target to maintain a Ramsay score of 3 to 4. When we look at how was the random, after 50 patients in each group, we stop the study. And you have to know that in your randomized studies will happen something like that the age was not exactly the same, was a little bit older patients in the control mode. They also have a slow but significant increase in the SAPS-3 score that translates in a almost interesting increase in expected mortality from the very beginning. So, little trouble from that. If we look at mortality, but we remember that our first project, our first objective was to reduce the days into the ventilator. So with this data, these were our results. As you can see directly here, nothing happened significant. So this is a negative trial. We failed to find difference in the total days of mechanical ventilation. If we separate the days in mechanical ventilation between the acute phase and the weaning phase, you can see that always there is no differences, nor ways, not differences in length of stay, nor in the hospital. And also we were exactly the same, the ICU and the hospital survival. So up to this point, we were unable to confirm our hypothesis. Any explanation? Can you suggest us some? Can you help us understand why it was so?
Well, you confirmed your first hypothesis. because then it would be as good as.
That's what our next, for sure, with a negative trial to demonstrate that was better than the one, but we can show that it was at least as comparable as controlled mechanical
So
ventilation.
let me oppose that. You have a patient difference in age and projected mortality that would say that if PAB was equivalent, it should do better, because you already are set to have in a CIS control patients who are already
Yeah.
older and sicker and have a higher projected mortality.
This is another way of doing, of looking at the data, because our main objective, that was length of mechanical ventilation, is hardly correlated with the severity of the score at the admission or the age. But anyone, to be sure that it's a non-inferiority trial, the matching of patients should be equilibrated.
So why didn't you see a difference?
When we look deeply in the numbers, so we saw what happened with blood gases. As you can see, in both groups, the arterial pH was comparable around the study, and as most of the physiological studies shows, you can see that PCO2 was close to normal from the very beginning in the proportional group, where our patients in control mode were slightly hypochemic, as commonly you can see in your ICU. Okay, patients in control mode commonly develop a slight hyperventilation in the beginning, and at the end are comparable. So, from the physiological point of view, it seems that our approach was good to maintain normal blood gases as expected. And when we look at what happens with failure, this is one of the important points on this study. As you can see, 22 patients, about 42% of patients, fail to be ventilated with proportional assist ventilation. So the physicians tried to use proportional assist ventilation, and 1 or 2 days after, they switched to assist control mode. And why was the reason? An important part of them, because they received deep sedation. So the patient was not anymore able to trigger comfortably the ventilator and to maintain a safe work pattern of breathing. Another, on the opposite way, is that for the physician it looks that the work of breathing was too high, that the patient doesn't look comfortably in this situation, and also because the respiratory rate seems too high for ordinary physicians in the ICU. And we can talk about what is that point. Is 25 is too bad for patients, 28, 30, 32, nobody knows exactly. But the point is that from the ordinary way of doing, for ICU physicians, they decide that this patient should not remain in proportional assist ventilation, and they switch them to control. So
I mean, those are, did you have guidelines that said when the respiratory rate exceeds X,
yeah.
you need to transition? When the work of breathing exceeds X, you had to. So you did
But
have
also we have a last point that
Judgment.
was, as much as the physician thinks that this is not good for the patient, you can also switch. And
So, I mean,
while
that's
they're-
tough for both of those, because some physicians will believe a rate over 20 is too high. Others, a rate
Yeah.
over 35 is still acceptable. So the variability
Mhm.
amongst individuals can be huge.
You have to remember that we only made 4 hospitals participating in the study, because after asking everyone between our friends, who is using proportional or not, who is confident enough to accept, to maintain patients in the middle of the night with proportional assist ventilation, only these 4 units accept that they were almost prepared to make this kind of thing. So, and finally, it seems that this was the perception of the bosses or the main investigators, but not for the rest of the team. So they still use deep sedation in some of them. They don't accept too much respiratory rate. So it's a hard part, and then one of our conclusions.
If you go back to the previous slide,
Mm-hmm.
so
So it seems, now the previous one before that, so it seems to me that if the patients who you enroll, on average, were spending 2 to 3 days on the ventilator, it's tough for any new, different ventilator to do better than that.
Sure.
So in a way, you're almost doomed from the outset
Yeah.
because these patients don't spend very much time on ventilator.
The point is that you don't know exactly for the very beginning who is needing longer mechanical ventilation or not. So you accept that your enrollment is that. And if you say at the interquartile range, it's a rise to 5 more. So the medium may be 5 days or something like that. But also,
But there
this
could
is-
be a lot that were just 1 day.
Yeah,
So,
sure. That's our point.
And then the other question I had is, do you know how many patients who were on volume control got switched to pressure support after 8, 10, 12 hours?
In the short thing,
Were they on assist control till they received a spontaneous breathing trial and fractionated?
yes, our guideline was
So there was no change in the assist control group, but there could be a change in that.
so then we try to make some answers for that, and we make a logistic regression analysis of variables related with failures. Let's say why these patients fail, and with all these variables, age, sex, hospitals, the only failure predictor that appeared was compliance. That means even with that we select patients with no terrific compliance, even the worst compliance also behave, needs to abandon PAP more frequently. And also an important point, hospital. As you can see, our rate of failure range from hospitals with 15% to 55%. So probably my advice, if you want to start a new trial on that, select carefully your colleagues, because from the very beginning everyone is more optimistic about the ability to work with that, but in the long term there is plenty of trouble appearing. Another way of looking at that is what happens, but it's always a try to confuse the audience and to convince that about the benefits of proportional. Let's say, what happens if you separate patients with PAP success and patients with PAP failure? So then you can see that the days in mechanical ventilation was really longer. The days separate between winning or not also are longer. The length of stay in the ICU is very long, and the survival doesn't change too much. So, but this is only the confirmation what kind of patients we have. So
So it only helps the patients who don't need any other ventilator.
maybe, or at least so short term, that the best way is to
I
take
get it.
out of the machine
I
as
get it.
rapidly. Yeah, sure. So, but we fail also to find differences in the need of sedation, in the ability to go out the ventilator even faster. So our conclusion was, even in selected patients, proportional assist could be an alternative to assist control from the acute phase of critical illness, but proportional didn't ameliorate any of the study variables. And the second one, that the high incidence of failure reinforce the need of high experience team and better patient selection in terms of compliance maybe, or better technological devices, because we don't know exactly all those points that I explained to you, that we say 80% help means 80% reduction in work of breathing, but if this is enough for weak people or not. Maybe it's too good for some patients that even they must perform so little muscular effort that are unable to clearly calibrate the effort. So maybe the rate of help may be also different, for not the same for everyone, despite our approach to try to rest the respiratory muscles. And this is my last slide. Thank you for your attention. So if you want to continue with some questions.
So let me ask both of you, based on your experience, what type of patients would you recommend the use of PAV, Umberto, or the use of Nava?
I before.
No.
Well, Nava, I think that Nava should be used in patients with the prevision of long stay, long mechanical ventilation stay, and in the patient that you have the possibility to switch from invasive ventilation to non-invasive ventilation by using the same catheter. This is a very important advantage. And second, I will use Nava every time that I don't understand what's happened. For instance, I realized that the sedation is a very important confusing factor, and when we switch from opiate and hypnotic sedation to desmetomidine, for instance, that do not affect the duty cycle as morphine or tidal volume as hypnotic do, we have, you can see immediately the change in asynchrony and the better capability to the better patient capability to breathe. Another point is that I don't want to use Nava in the very sickest patient when the patient is very acute, because at the moment we don't know how the Nava can follow the patient requirement. I have a very sick patient, an RDS patient. I don't feel comfortable to use Nava per se. I prefer to use Nava as a monitor, just to see what's happened, and then to think about it. And moreover, there are a good Nava application in donor for lung transplantation, and also in the patient after cardiac surgery, as I said before.
I like your, I'm sorry, Bob.
No, I was just going to say, what percentage of your patients do you use it on then? 5%, 50%?
Well, now we have just finished a randomized study about Nava in the term of winning outcome. And in the winning outcome, I can anticipate that Nava play a role compared to pressure support. In my intensive care, 16 beds, we use more or less 5 patients in a month.
In a month?
Yes.
Okay, so small percentage.
Small
maybe
percentage.
20% of
And
your patients.
and moreover, it's very important to train the fellow, because you can see what before we come.
Right.
So I like your point about using it as a monitor, and I have tried to encourage the folks at McKay to develop a box of monitors, so it could essentially be used with any ventilator, and you would not have to use it with PAV.
You've been unsuccessful, right?
Correct. It's not going to happen. But because they want you to buy the ventilator and the software and the whole thing, you know. But my own bias is that in the hands of a skilled clinician, if you had that monitoring, you could probably make many modes work better.
Yeah.
And so I agree. I agree with that point. And I mean, here, what we do, some of us, what I do is in the type of patient you described, I put in an esophageal balloon catheter,
Yes.
and then use that to titrate them in later settings and so forth. And I can see how the Nava catheter without the Nava mode could perhaps be used in the same way.
Yes. Another suggestion, if you have another kind of ventilator, so it's difficult to buy 25 or servo-wire ventilator. So what I suggest
how much
is
money you have.
just to have one, and you can use the servo-wire ventilator with the phantom lung, but with the catheter inside the patient, and with the patient ventilated with the other ventilator, you synchronize the both just by occlusion, and then you can monitor. And this is very useful.
Sound like somebody who works for McKay.
Well, thank you both for your presentation. It was very good. I've been watching this for many years, and it's difficult to show an advantage of one mode over the other. I'm not sure that any mode's ever been proven to have any real advantage. But when I listen to your presentations and over the years thinking about Nava and PAB, particularly Nava, boy, it's interesting. It's great. It seems like we've arrived where we should have been. And it works, and you're showing it works. There's no doubt about that. But what's the hurdle? Why aren't we using it more? We don't have much Nava here, but even the PAB here. We have machines with PAB. We just don't use it. I think the quick answer is pressure sport's good enough. But as we strive towards excellence in all sorts of things we do, maybe we should think about this a little bit more. And sure, pressure sport's good enough, but maybe we should make more of an effort to make this next step. And I really like Nava, although I haven't had a chance.
But his data would not.
But his data would show me I'd be very comfortable exploring. Exploring it,
But
not
Rafa's data shows you why people don't use PAB or Nava.
Yes, for us, we think that there are two different problems. One is even up to now, there is not an easy way of ventilate patients. And the other thing is that definitely it's not possible to find a way of a method of ventilation that can improve any kind of patient. So this kind of trials to making any kind of patients in the box and try to find differences, I think that is a wrong approach, because probably even the advantages can be very little, or for very specific patients that we are unable to figure out when they are inside the box with all the rest of the patient. For example, the sensation that all physicians have that patient in pressure support ventilation behaves perfectly. And you see that the tracing from Umberto, they say it looks perfectly, but inside the patient is making an effort, or on the contrary, they are completely apneic and becoming atrophic. And you have no any meaning from the clinical easy arena to say that this patient next week, when you try to take off the ventilator, is unable to breathe. But no one relates that with the point that the last week he was almost comfortable in pressure support ventilation, because it's so tricky that you are perfectly convinced that things are happening correctly, that the next problem there is maybe because it's septic associated weaknesses or something like that, nothing that you can relate with your previous ventilation approach. So this is one of the troubles, and to find only these patients to improve with PAF or with Nava is so difficult because we cannot anticipate. It's very difficult to find in advance to submit to the best ventilator mode for these specific patients. So I think that can be the reason why years after years studies are unable to find strong improvements in patients, because and also because the other part that can be is good for patients, that is not to become atrophic from the very beginning, can be overcompensated for patients that if you submit in the very acute phase for a spontaneous mode, they develop high tidal volume, high stretching of the lungs, and finally ventilator-induced lung injury because with Nava or with PAP, we allow them to take 800 milliliters per kilogram. But we also doesn't see that at the moment, but 1 week after. So at that point, I am unable to suggest what patient should be offered a trial of proportional assist ventilation. Of course, as we behave in the day-by-day approach, at least in our unit, that if, when something is not good with assist control or with pressure support, we try proportional. If the patient behaves better, this is all something that consistently happens. There is specific patients that prefer to breathe with proportional assist ventilation.
But you wouldn't know unless you
You
trial
try
and
it,
error.
yeah.
So I'm curious in your trial why you compared a mandatory mode against a spontaneous mode, and why not a spontaneous mode against a spontaneous mode, PAV against Nava, PAV against pressure support.
Because our approach was to try to offer an advantage for the standard way of doing it. And the standard way of doing our unit is to use assist control mode from the very beginning. So they say, is there any help of a spontaneous mode in this phase? So that was the reason our control group was the standard clinical approach.
But you started with a disadvantage to begin with, because most of the time when somebody is on control mode, they need to be more sedated and so on and so forth. But if we're going to introduce PAV, so that puts you at a very big disadvantage to begin with, because
And despite that, they came out the same.
yeah, but you'll have to look also and see, did that set any of these patients back by putting them on the PAV to begin with in the acute phase? Did they spend any more time on ventilation, mechanical ventilation than they needed to, or did they get sicker, or did they not survive because of that?
That is all our unanswered questions.
So both of you talked about improved synchrony. So it seems to me the right patient to randomize is the patient who has high levels of asynchrony that cannot be easily corrected by manipulating the ventilator, because that's the patient, in my assessment, that would have the potential greatest benefit from going to either of these modes. So it may be the way the patient you selected, all comers, the vast majority of those patients, nothing was going to have any impact, because they're going to do fine no matter what you did. But if you teased out those patients with asynchrony indexes greater than 10%, Luis?
Yeah, yes.
Greater than 10%, who we know have a pretty bad outcome, lengthy periods of mechanical ventilation, and randomize them, might you have seen a very different outcome in the trial.
We don't focus our attention to patients with asynchrony because our clinically oriented trial was to try to improve something from the clinical point of view. And up to now, I don't know how many ICUs uses any kind of asynchrony observation in the day-by-day. Do you look at asynchronous in your patients?
The bedside clinician
Not
does.
systematically, only when
Yeah.
You'd be
something
looking at
happens.
the screen.
We look at it
Oh yeah,
every time we go to the bedside.
and you pick up even this little tiny signal that
Which
Humberto
we-
said show us that can have big diaphragmatic excursions.
I'm sure that not everyone picks up everything.
Yeah.
I
but at
think it's
least you have this
impossible. I think,
approach.
but in general, yes. I mean, I think that we look at the waveform, we look at the patient, we listen to the patient, and we do have a lot of skill in that area. Yeah.
Yeah, I mean, our experience in plenty of conferences is that very few people in the audience in day by day make this kind of examination. So from our point of view, if our first inclusion criteria was patients with troubles of asynchronous, there will be very few physicians involved, very few units participating, because at least at present, there is few people really
So this is a very good advertisement for coming to Friday's lecture. It's when Luis is going to tell you about an automated database that will be able to give you, on a continuous, real-time basis, the level of asynchrony. And that's what you need to be able to do what you're saying. I mean, you need to be able to do it clinically. I agree with Linda, you know, but you are right. When you go to talk to the average physician, and I would include the average respiratory therapist in most hospitals, they don't pay attention to waveforms. They don't understand them, and they have no idea, you know, what they mean.
And it's
That's the
hard to
most
have it.
important part of our job.
I agree with you, but if you go out there and talk to people in other institutions, you'll be amazed how little time they spend looking at them.
The other thing is, I think that watching patients over my entire career have T-piece, pressure support, full support, no support, late support, too much support, it doesn't make a difference in the big picture. They survive, whether they will. What we don't want to do is injure them, but I don't think we can heal them with a ventilator. We just don't want to injure them.
Our approach was if some of these spontaneous methods can allow not to get more harm for patients, like more sedation,
Exactly.
but
Exactly.
at least in our first shot, we failed to find maybe better selection of patients.
Like you said, a large number of patients are going to come off the ventilator when they're ready to come off anyway, and it's uneventfully. But
Well, this is a very physiological, interesting point of view. You mean that no matter what you are in charge of any other ignorant patient?
well,
No, I think that maybe
some don't
very-
take as much attention. A lot of them don't, and then some of them take a lot of attention. You know, require a lot of interventions. But I think that we always look at asynchrony, but the way we evaluate it is so subjective. There's no systematic. We don't have a way that counts it, counts each event. or how many-
Not yet.
Not
Maybe
yet.
on Friday.
But maybe we will soon. That's right.
But in those who have done that, there clearly are numerous papers that show a relationship, association, not a cause and effect, but a relationship between asynchronies and outcome. That if the more asynchronies you have, the poorer your outcome.
Or if
Because
you're gonna
our-
die, you have more asynchronous.
Yeah.
Or maybe you're
It could
should be
either
more
way,
sedated
right?
and
So
have
you
no
can-
asynchrony.
We can't say
we
which
cannot tell.
But
Yeah,
even
you
so,
can't tell which direction it
We
is.
cannot tell.
Is a diaphragmatic weakness worth it for the sedation?
But let me think a little bit after your talks and even these results of one study that we have been waiting 20 years to see some study, multicentric, randomized, pressure support, but now the result seems really poor. You know what I mean? Rafa knows how to ventilate patients with PAF. His hospital is the 5% withdrawing PAF, and other hospitals with really good physicians trained, they don't pay attention. And this is a problem. Now, for example, I came from different regions in Spain talking about synchronous teaching people, and people say, wow, this is too complex. And then they spend maybe 10 days looking one of these numbers that came out from these hemodynamic devices, whether it's 2.4 or 2.2 cardiac index in a patient who is pain, who is red, who is talking, who has normal lactate or whatever, you know what I mean. So I think there is something in all that we need to stress. When the patient is recovering, so the patient has normal lactate, no fever, norepinephrine is going down, all these things, what's the major problem? What's the major problem? The ventilator. And then we are starting winning. And if we start winning, there is no... So there is something there that interferes with the cure, to cure the patient, which is maybe this process of mechanical ventilation. And after hear you, so now you, Rafa, let me be a little bit provocative, are talking on something that I am astonished. A non-inferiority trial on PAF. So a non-inferiority trial on something that causes lots of flow dysynchrony, ineffective effort, which is assist control ventilation. So this is dramatic to me, because everybody thought that PAF was very interesting, or even Nava,
But here, I mean, this people is good. Nobody uses PAF or Nava. What we use? Pressure support. Now there is that article of Georgopoulos in the Respiratory Physiology saying that in difficult to win patients, they compare PAF, Nava, and pressure support. And if you said pressure support, okay, no difference. No difference in terms of, you know, the recent study there in work of
Takes a
breathing.
good